Good afternoon, everyone. My name is Rajkumar Venkatramani. I'm a pediatric oncologist at Baylor College of Medicine, Texas Children's Hospital, and I have the pleasure of moderating the webinar entitled Approaches to Recurrent Rhabdomyosarcoma for the American Society of Pediatric Hematology Oncology. I have a few housekeeping items before we get started. Please note that all the participants have been muted for the presentation this afternoon. I would like to direct your attention to the chat room on your screen. Please use this chat room to ask any questions, which I will direct to the speakers at the end of the presentation. You can also use this area to let me know about any AV issues or technical difficulties that you are having during the presentation. So the topic today is Approaches to Recurrent Rhabdomyosarcoma. We have two excellent speakers today. The first speaker is Dr. Leo Mascarenhas, Associate Professor of Pediatrics at Children's Hospital, Los Angeles. The second speaker is Dr. Douglas Hawkins, Professor of Pediatrics at Seattle Children's Hospital. We will start off this presentation with two clinical cases, which will give us some context to the presentation. The first patient is a 4-year-old female with orbital rhabdomyosarcoma. She presented with growing mass in the left orbit at 3 years of age. The initial biopsies showed embryonal rhabdomyosarcoma, and she underwent resection with negative margins. She was treated with vincristine weekly combined with actinomycin D for 5 days every 3 weeks for 39 weeks. She did not receive radiation therapy. 9 months after the end of therapy, she presented with a 2-centimeter recurrent mass in the primary tumor site. She underwent surgical resection. Subsequently, she presented to Texas Children's Hospital for subsequent management. So this is her scan when she presented to our hospital. As you can see, there is a residual tumor in the surgery site. So we have the first audience question. Think about if the patient comes to you, what would be the most appropriate treatment option for this patient? You have 5 options. You can click, it should appear on your screen. Please click the option you think is the most appropriate. I'll give you 5 more seconds, then I'll go to the next slide. Thank you so much. We'll come back to this question later in the presentation. The second patient is an 8-year-old male with abdominal rhabdomyosarcoma. He presented with abdominal pain and vomiting. The CT scan at presentation showed 6 by 5 by 4 centimeter abdominal mass. The biopsy was reported as embryonal rhabdomyosarcoma, but it was unresectable at diagnosis. So he was diagnosed as stage 3, clinical group 3, and was treated as per ARST 0531 with VAC-VI regimen. And he underwent surgical resection after 4 cycles. They also received radiation therapy. You can see the scan at diagnosis on the left side of your screen, and it shows a tumor in the pelvis, and then the response to treatment after 4 cycles where the tumor becomes smaller and subsequently was resected. Unfortunately, at the end of therapy, during his end of therapy scan, we found new pulmonary nodules in the CT of the chest. That comes to our second audience poll question. For this patient, we have the same options. What would be the most appropriate treatment option for this patient? Please click on the option in your screen. I'll give you 5 more seconds to enter your answer. Thank you for responding to the poll. With that background, I will hand over the presentation to Dr. Mascarenhas.
Thank you, Dr. Venkatramani. And so what I'd like to do with my section of this webinar is actually speak about the historical perspective and then present results on 2 prospective clinical trials conducted by the Children's Oncology Group in first relapse rhabdomyosarcoma. So the very first report on first relapse of rhabdomyosarcoma was actually published in 1983 by Dr. Rainey and colleagues, where they looked at patients who were treated on the first intergroup rhabdomyosarcoma study, which was between 1972 and 1976. On that particular study, there were 80.6% of the patients received complete response, and this is higher than expected, but it's probably reflective of the imaging technology which was available at that time. Of those who received complete response, 33.7% relapsed. They collected relapse information by questionnaire to the treating oncologists, and 85% of the patients, there was sufficient information. In 13 of 98 patients, there was a local recurrence only. Those which were unfavorable were really the perineal, gastrointestinal, retroperitoneum pelvis, and extremities sites, which were at the highest risk for distant or multiple sites of recurrence, while those who had orbital tumors or genitourinary tumors, which were non-alveolar in histology, had the lowest risk of recurrence. 92% of those patients received some subsequent treatment, and of which 37% went into a second complete response. Of all those patients, only about 5% of them were tumor-free at the time of writing this report, where 17% of patients with a local recurrence and 4% of the patients with distant recurrence. So this gave us some idea that that alveolar histology and unfavorable sites were at highest risk of recurrence, including those who had multiple sites of disease, and that long-term prognosis was poor. The next information came to us from the International Society of Pediatric Oncology with a malignant mesenchymal tumor study 84, where they looked at patients who relapsed following the treatment of non-metastatic rhabdomyosarcoma. The median time to first relapse was 14 months, with a range of 2 to 69 months from the time of diagnosis. The important thing to know is that 78% of the patients recurred within 2 years of initial diagnosis. Alveolar rhabdomyosarcoma had a significantly higher risk of relapse compared to embryonal rhabdomyosarcoma, and alveolar rhabdomyosarcoma patients also had a significantly higher risk of distant relapse compared to embryonal rhabdomyosarcoma. The 5-year-old overall survival in this population was 0, and for those with local, the 5-year-old overall survival for patients with local recurrence was 41%. If you look to see those who were treated with chemotherapy alone, for those patients who were initially treated with chemotherapy alone, the survival was 46%, while those who were treated with both chemotherapy and radiation initially, their survival was inferior at 29%. And this leads us to the seminal publication based on data from the IRS-3, IRS-4, and IRS-4 pilot, which all occurred between 1984 and 1997. In that population of patients who were treated, there were 605 patients out of 2,364 which relapsed, for a relapse rate of about 25.6%. Again, the time to relapse was reasonably short, with patients relapsing a year after diagnosis, but the range was 1 week to 9 years. 95% of all relapses occurred within the first 3 years of initial treatment. 35% of them were local relapses, 16% of them were regional relapses, and 41% of them were distant relapses, and there was no data on 8% of the patients. About 8% of the patients had no radiotherapy at initial treatment, and those patients were group 1 patients on IRS-3 and stage 1, stage 2 patients who were group 1 on IRS-4, and patients who had vaginal or vulvar primaries attaining complete response with chemotherapy alone on IRS-4. There were 14% of patients who received chemotherapy with vincristine and dactinomycin alone. As you can see on the Kaplan-Meier curve on the right of your screen, the median survival after first relapse was about a little over 3/4 of a year, and the 5-year overall survival of this population was only 17% after almost 5 years of follow-up. If further looking at the data on these particular patients, you can see in this Kaplan-Meier curve on the upper left side that patients with botryoid histology had a 64% chance of being alive, while those with embryonal histology, it was 26%, but with alveolar or undifferentiated histology, it dropped to 5%. When you look at histology on the right-hand side of your screen, for those with alveolar histology and who had group 1 tumors, the 5-year survival was 40%, but then the combined survival for patients with group 2, group 3, and group 4 tumors was only 3%. Patients with embryonal histology fared slightly better. If you were group 1, you had a 52% chance of long-term survival. If you were group 2 or 3, you had a 30% chance of long-term survival. But if you had distant metastatic disease or group 4 at original diagnosis, then your survival was only 12%. And if you look at stage, there was an effect of stage over here, initial stage 2, with a lower stage having the best survival and higher stage having a poor survival. So this led to a sort of stratification for those patients who had a likelihood of being cured after first relapse, and there was a favorable group where the 5-year survival rate was about 50%, but they accounted for only 20% of all relapses. And those were patients with botryoid histology tumors, patients which were stage 1 or group 1 tumors that experienced a local or a regional relapse, and group 1 alveolar tumors. All others fell into the unfavorable category, where the 5-year survival rate was about 10%. So the Italian published their data from 3 successive studies of non-metastatic patients, which are outlined over here. There were 125 patients. Again, the median time to first relapse was about 18 months. They had a high number of local recurrences, 72%. The overall survival of this cohort was only 28.3%. The prognostic factors which they identified were alveolar histology, a parameningeal site, a metastatic recurrence, and any recurrence which occurred on treatment. If the patients had an absence of any of these adverse prognostic risk factors, the 5-year survival was about 72%. And if they had a single risk factor, the 5-year survival dropped down to 37.5%. Then they did an interesting analysis where they combined patients who had no risk factors, so that's the group which had a 72% survival, and those who had one risk factor, which is the group which had 37.5% survival. And if there was no history of radiation therapy, that group had a survival of 66.5%, while those who were previously treated with radiation, their survival dropped to 30.3%, suggesting that that was an important, that past history of radiation therapy affected prognosis adversely. The malignant mesenchymal tumor studies 84, 89, and 95 also looked at 74 patients who had suffered a relapse. In that series of patients, poor outcome, metastatic recurrence, history of radiation during initial treatment, initial tumor size of greater than 5 centimeters, and time to relapse of less than 18 months from initial diagnosis were associated with a poor outcome. Additional factors included unfavorable primary site, lymph node involvement at initial diagnosis, alveolar histology, and treatment with greater than 2 drugs at the time of initial diagnosis. And this led them to actually develop a nomogram, which is highlighted over here, and you can see all the prognostic factors on the left side of the screen. And if you look at this nomogram, the higher the score you received, the better the chance that you would actually survive. This is what they've used to assess the risk, the prognosis following first relapse. There's really been only one study which has addressed the issue of local tumor control in first relapse rhabdomyosarcoma, and this is data which comes to us from the German groups and was based on the CWS 81, 86, 91, and 96 studies, but it only addressed alveolar rhabdomyosarcoma patients. In that cohort, they had 115 relapses out of 235 patients, so about a 50% relapse rate, which seems appropriate across the board. The median time to relapse was again 1.4 years, but some relapses occurred as late as 4.8 years. They had treatment data available on 99 of the 115 patients, so a significant number of patients. There were 43 local recurrences. 9 patients received no therapy, and those patients who didn't receive therapy were all dead after a median time of about 2.5 months. There were 51 of 90 patients achieved a second complete response, and 32 of 51 patients suffered a second relapse. And after a significant follow-up of over 8 years in surviving patients, there were 22% of patients who were alive, and one after suffering a second malignancy. So that patient was a second remission from the second malignancy as well as from rhabdomyosarcoma. The median time to death after relapse was 1 year, and there were 2 non-disease-related deaths in this population. And when you looked at the factors which increase the risk of death in this population, there were patients who had nodal involvement at the time of initial diagnosis. The patients who had distant metastases or multiple sites of metastases had an increased chance of relapsing. And then patients, ALRT stands for adequate local relapse treatment. So this is either surgery or radiation therapy. If they were able to achieve it, they had a better prognosis. And those patients who achieve a second CR also basically had the best prognosis among these relapsed patients. And this is shown in this Kaplan-Meier curve on the right-hand side, with the most favorable group having a survival of about 54%. So this leads us to the first prospective trial in first relapse rhabdomyosarcoma, which was conducted by the Children's Oncology Group, ARST0121. Patients who were classified as unfavorable risk were those patients with alveolar histology, patients with stage 1 Group 1 embryonal rhabdomyosarcomas with distant recurrence, and stage 2, 3, and 4, group 2, 3, and 4 embryonal rhabdomyosarcoma patients. Those patients who were considered favorable risk at the time of relapse were those with botryoid histology at initial diagnosis, or stage 1 or group 1 embryonal rhabdomyosarcoma patients who did not receive an alkylating agent prior and had only a local or regional recurrence. Here is the treatment which they received. The unfavorable regimen patients basically were randomized to vincristine with a prolonged or a short course of irinotecan, and those patients who responded continued to receive doxorubicin and cyclophosphamide, ifosfamide and etoposide, and the selected vincristine irinotecan regimen, which they responded to for 44 weeks. Those patients who had stable disease or who had progressive disease went on to receive doxorubicin and cyclophosphamide together with hypoxic cell toxin, tirapizamine, and then later alternating with ifosfamide and etoposide. The favorable risk patients just received doxorubicin and cyclophosphamide alternating with ifosfamide and etoposide for a total of 31 weeks, and the doses and schedule are given on the right-hand side of this table. This is the distribution of patients. There were only 14 favorable risk patients who were treated with the doxorubicin cyclophosphamide alternating with ifosfamide etoposide. The largest group of patients were patients who were eligible to be randomized between the prolonged irinotecan regimen and the short irinotecan measurement, of which there were 61 patients who had less than a partial response, and those patients automatically went on to be treated with the doxorubicin cyclophosphamide together with tirapizamine and later alternating with ifosfamide and etoposide. And there was a group of patients who did not have measurable disease or who refused randomization, which were also included in that cohort. These Kaplan-Meier figures are the outcome of patients who were randomized to the vincristine irinotecan window and then received subsequent therapy with that window regimen incorporated with doxorubicin cyclophosphamide alternating with ifosfamide and etoposide. And you can see that the 3-year failure-free survival was only 15% in that group of patients, and the overall survival was 28%, and there was no real difference between the two regimens. The median time to first progression after first relapse was only about 6 months. There was no difference in the response rates between the two regimens. The patients with alveolar histology had a significantly higher response rate compared to embryonal histology on those patients who were treated with a shorter regimen, but there was no difference in the prolonged regimen, and there was more neutropenia on the shorter regimen, though there was no increased risk of febrile neutropenia in that group. When you look at patients, in the favorable risk patients, you can see that the failure-free survival when they were treated with doxorubicin cyclophosphamide alternating with ifosfamide and etoposide was actually very good, with a survival of 84% at 5 years and an event-free survival of 79% with that therapy. So this was the single largest clinical trial in first relapse rhabdomyosarcoma. Poor prognosis patients who relapse with alveolar rhabdomyosarcoma, advanced embryonal rhabdomyosarcoma, or those treated with alkylating agents at initial diagnosis basically continue to have a poor prognosis and are really candidates for experimental therapy, while those who had a favorable prognosis, the low-stage embryonal rhabdomyosarcoma patients or botryoid patients, those patients are really candidates for experimental therapy only at second progression and should be offered therapy with doxorubicin and cyclophosphamide alternating with ifosfamide and etoposide, since they have excellent outcomes with that regimen. So this led to the second prospective trial, which was ARST-0921, which was a randomized phase 2 clinical trial of bevacizumab or temsirolimus in combination with chemotherapy for first relapse rhabdomyosarcoma. This was limited to those who had an unfavorable features. The chemotherapy backbone which was selected was vinorelbine and cyclophosphamide based on previous trials and publications of the activity of those agents in this disease. And the biological targeted agents, bevacizumab and temsirolimus, was selected based on preclinical data on rhabdomyosarcoma with VEGF blockade and mTOR inhibition, and more importantly that we actually had recommended phase 2 doses of both those agents, and safety assessment had already been completed. So this was the treatment regimen which was used. Both arms of the trial got an identical cytotoxic chemotherapy regimen with vinorelbine on days 1 and 8 intravenously, cyclophosphamide on day 1 intravenously, and patients on regimen A got bevacizumab once every 3 weeks at a dose of 15 milligrams per kilogram, and those on regimen B got weekly temsirolimus at a dose of 15 milligrams per meter squared. All patients received myeloid growth factor starting on day 9. And you can see this trial was actually stopped early because of a superior survival, superior event-free survival at 6 months of patients who were treated on the temsirolimus arm. And that advantage in survival actually continued to 4 years out. There was no difference, however, between the two regimens in terms of overall survival, and there was no difference in the response rate between the two arms of the trial. There was a higher incidence of toxicity on the temsirolimus group, but this was not statistically different from those treated with bevacizumab. And this tells you that even while the initial 6-month survival seemed to be quite good, there's actually a drop-off with on regimen B of the temsirolimus arm, where the survival dropped from the event-free survival dropped from 69% to 45 at 6 months to 41% at 12 months and 19% at 2 years. So patients with first relapse rhabdomyosarcoma treated with vinorelbine and cyclophosphamide and temsirolimus had a superior EFS compared to patients treated with vinorelbine and cyclophosphamide and bevacizumab. There was no response rate at 6 weeks and the 2-year survival between the two regimens. Temsirolimus is now is being studied further by COG in newly diagnosed intermediate risk rhabdomyosarcoma study patients on ARST-1431. And with that, I would hand over to Dr. Hawkins to take this forward. Thank you.
Thank you, Dr. Mascarenhas. So I would like to outline a general strategy of how to approach patients with apparent recurrent rhabdomyosarcoma. And I think there are a few basic principles that are important to remember when approaching these patients. First, in virtually all cases, it is important to confirm the first recurrence with a biopsy. The reasons are multifold, but perhaps the most important is that the prognostic implications, as Dr. Mascarenhas outlined, of a recurrence of rhabdomyosarcoma are enormous. And so it is incumbent on us as physicians to be quite confident of the recurrence. There may be unusual circumstance where imaging features are completely consistent with recurrence, but in most cases a biopsy is necessary. There are a number of radiographic features that can mimic recurrence or relapse. That includes a persisting mass at the end of treatment, which at the time of biopsy may show differentiating rhabdomyoblasts, which don't necessarily confer an unfavorable outcome. There are changes that can appear radiographically after radiation. In the case of pulmonary nodules, they may represent infection in an immunocompromised host, as well as other features that on radiographic imaging may look like recurrence. In addition, this is an opportunity to obtain tissue for more comprehensive sequencing, particularly if it had not been done at diagnosis, or even if it had been to identify new abnormalities that may have therapeutic implications. I'd like to mention briefly a justification for this approach to biopsy at the time of recurrence, which is to obtain tissue for enrollment on the pediatric match. This is a COG-NCI study that has a hypothesis that biomarker-driven matching of a actionable mutation or actionable abnormality identified at the time of recurrence to a specific therapy may lead to an improved outcome. This study starts with enrollment and obtaining tissue at recurrence. It is required to go on in the study to have tissue that is obtained either at the first refractory state or at the time of recurrence in order to be eligible for the study. Once tissue is obtained, there's a standard battery of testing that is done to identify a predefined list of abnormalities, which then make patients eligible for enrollment on a specific phase 2 study that matches the therapy to the molecular abnormality that's identified. So the point here is that tissue obtained at recurrence is necessary in order to enroll on this study that may provide a patient-specific treatment option. In addition to confirming recurrence, the next step, I believe, is to review the prior therapy. One can ask the question, was there any deviation in the treatment that was used that might have contributed to relapse? For instance, did one choose to omit radiation because of the patient's age, or did one choose to use a different dose of an alkylating agent due to concerns for toxicity? In addition, one needs to look at the prior agents and the cumulative doses employed to first pick agents that may not have been employed before for second-line treatment, as well as to consider prior cumulative doses that may make it prohibitive to continue to give the same agent in second or third line. The next important question is to consider whether further local therapy is feasible. The majority of recurrences and initially localized rhabdomyosarcoma are local regional, and it may be possible to deliver effective local therapy at second line. The question could be asked, if someone has already received radiation, is there an option for reirradiation, or is there an option for surgery, which may come at some considerable morbidity cost? All of these discussions, I think, have to be made within the context of the goals of care. As Dr. Mascarenhas outlined, the prognosis for some of these patients is really quite poor, and the patient and family goals for care are very important in determining the intensity of treatment and the morbidity one is willing to accept. And in that case, I think early involvement of your local palliative care team is quite important. And then finally, when making a decision about treatment, I think one needs to know about the relative probability of response or prolonged post-relapse survival to make an informed decision about the type of treatment to offer. So that if the probability of a response or prolonged survival is high, in the cases that Dr. Mascarenhas had outlined, then there may be a standard of care regimen which is very reasonable and would be preferred. On the other hand, if the probability of response or post-relapse survival is low, enrollment at the time of first recurrence on a phase 1 or phase 2 study may be quite reasonable. Now, how can one decide all these things? Well, before I go on to that, I should mention that there's been a very good review article that discussed a variety of issues with rhabdomyosarcoma, including the approach to patients with refractory or recurrent rhabdomyosarcoma, putting forward an algorithm as shown on this slide. Many of the issues which I've mentioned already, biopsy to confirm recurrence, considering obtaining tissue for molecular genotyping or phenotyping, considering prior therapy, goals of care, and then deciding whether either a clinical trial enrollment or a standard of care option would be reasonable. These are outlined in this review paper published last year. This paper also presented data on a variety of second-line treatment options, and I've modified the table from this manuscript to describe treatments that have been published or are in press that have been used in second-line treatment. Now, it is very important when looking at these different regimens to be careful about comparing one of these treatments to another, because these different regimens were studied in different ways and may not have been restricted just to the most unfavorable patients, and in some cases they are reflecting institutional experiences rather than prospective clinical trials. But I think one can see that there are a number of regimens that have been studied in a moderate number of patients that have a reasonably high response rate, and at least some data about what the early short-term event-free survival is after recurrence. But again, I caution you to compare these regimens across studies because they are not exactly the same study populations. But these provide good regimens to refer to in the literature to make choices about treatment for your patients. In addition, one needs to consider what investigational trials are open, and this is a list of it, that I've compiled from the Children's Oncology Group of Phase 2 studies. I did not include Phase 1 studies, of which there are many more options, but Phase 2 studies that have rhabdomyosarcoma cohorts. In some cases, I have included Phase 1 studies that have planned expansion cohorts to include rhabdomyosarcoma. And in each case, you can see that there are a variety of targeted agents, and the targets are described here that either have recently been opened or are planned to be open within the Children's Oncology Group. So there are a number of actively enrolling studies that may provide options for patients who have a particularly poor prognosis given their features of recurrence. And with that, I will turn the discussion back to Dr. Venkatramani to go back to the cases that he presented at the beginning.
Thank you, Dr. Hawkins. Before we go to the actual cases, I want to remind everyone, if you have any questions, please type it in the chat box, and I'll direct those questions to the presenters. So this is a good time for you to type your questions in the chat box. So we're going to go back to the two cases we presented at the beginning of this presentation. Just as a reminder, the case one was a 4-year-old female with orbital rhabdomyosarcoma who had a local recurrence with residual disease, and her prior therapy was VA without any radiation therapy. So it's a time for you to participate in the poll again and to see if you had to change your answer based on what you heard, and then we'll ask Dr. Mascarenhas about what he will do. I'll give you about 10 seconds to answer the question. So, Dr. Mascarenhas, while they're answering, what would be your treatment option for this patient?
So to remind everyone, I mean, the patient had his original tumor in the orbit with embryonal histology and was a group 2 patient. So at the time of recurrence, this patient actually has a favorable prognosis. The second important thing to note was that the patient, even though the patient had group 2 disease, should have actually received radiation therapy and did not receive radiation therapy. And patients who did not receive radiation therapy when they relapse have a better prognosis. So in my opinion, the best chemotherapy regimen for this patient would be doxorubicin, cyclophosphamide, ifosfamide, and etoposide, in an alternating regimen very similar to regimen 3 of ARST 0121. And further, this patient should have adequate local control. Since this patient did not receive radiation therapy previously, I think radiation at this time would be very reasonable, and that might save the eye. If the patient had received radiation therapy previously, more aggressive local control is probably warranted to cure this patient, and a resection of the tumor, which may include an orbital exentration, could have been considered. And it looks like the majority of the audience got this right.
Dr. Hawkins, do you have anything to add to that?
No, I agree with everything that Dr. Mascarenhas had said. I think this, whether vinorelbine cyclophosphamide 10-sirolimus would achieve a similar event-free survival is unknown. That has not been studied, but it is hard to argue with the outstanding outcome that Dr. Mascarenhas presented from that favorable group with the doxorubicin, cyclophosphamide, ifosfamide, etoposide. I think the likely there may be more long-term toxicity with those agents in a group of patients that have a high chance of cure. But in the absence of data saying that the temsirolimus regimen is equally effective, I think the proven standard of care treatment would be the one that has been outlined and selected by most of the audience.
Thank you. So going back to the second case, this, to remind everyone, this was an 8-year-old male with abdominal rhabdomyosarcoma, embryonal histology, was treated as per ARST 0531. At the end of therapy, unfortunately, he had a metastatic recurrence in lung. What would be the most appropriate treatment option for this patient? Please choose your answer from the screen. Thank you, everyone. Dr. Hawkins, how would you approach this patient?
I think there are a couple of approaches one could consider. The audience selected the vinorelbine cyclophosphamide temsirolimus option. That we certainly have a large series of patients treated prospectively at first recurrence treated with this, and so we know that the outcome for that, at least the early response rate and early disease control, is reasonably good. However, a patient like this would be predicted to have a low, less than 20% chance of prolonged disease post-relapse survival, and one could consider this patient to be a reasonable candidate for enrollment on a phase 1 or phase 2 study, given the relatively poor long-term outcome. So I think certainly consideration of enrollment on a phase 1 or phase 2 based on availability of agents and goals of care for the family would be reasonable. I think it's interesting that the audience did not pick doxorubicin, cyclophosphamide, ifosfamide, and etoposide at a high level. Only 7.5% picked that, and those are certainly well-described regimen therapies. But I suspect that the audience may be making a toxicity trade-off, assuming that the toxicity may be lower for vinorelbine, cyclophosphamide, temsirolimus than the other combination. And given the fact that it is not clear, we've never compared these two regimens head-to-head, but there's no evidence that the more complicated regimen is likely better. I think that may reflect a toxicity trade-off without favoring the less toxic and potentially equally or more efficacious regimen.
Dr. Mascarenhas, do you have anything to add?
I agree with Dr. Hawkins broadly on this, and I think vinorelbine cyclophosphamide temsirolimus is a reasonable regimen for this patient, as is the doxocycloifosfamide and etoposide. But the toxicity may be significantly different, and so from a quality of life perspective, and these patients have a poor prognosis, it's something to consider in making that decision. In terms of a clinical trial, I think if we had a reasonable clinical trial which potentially had some cytotoxic therapy with something else where these patients would potentially respond to, would be a determining factor. I think I would hesitate to offer them a phase 1 clinical trial right away at first recurrence, as there are regimens out there which can offer the patient some potential of benefit, albeit being short-term. So I would probably reserve a phase 1 clinical trial for somebody who's in a second recurrence or beyond, because those patients are virtually incurable. But if it's a good phase 2 clinical trial where there's strong data and there's a likelihood of response, that may be a reasonable option for this population of patients who has a poor prognosis. And as always, I think you have to consider the goals of the the goals of the patients and the family in making that decision.
Thank you. So it's time for audience questions. We already have some questions here, so I'll go over one by one. The first question here from our audience is, if the patient has a radiation initially and they relapse and it's not resectable by surgery, would you consider re-irradiating that same site for local control?
Okay, this is Doug Hawkins. I'd be able to take a stab at this. I think this, we probably don't have the right representation for an expert answer because we really need radiation oncologists to say what would be the morbidity of re-irradiation. I think this may be a situation where particularly highly conformal radiation might be an option, whether that's protons or stereotactic body radiation as to radiate a smaller volume than the initial volume. But I think there may be some normal tissue tolerances that may prevent re-irradiation. But I think that this is a great consult question to ask an expert radiation oncologist: is it feasible to re-irradiate? Because that actually may be a reasonable strategy. Dr. Mascarenhas, any other comment about that?
I agree with you completely, and it probably may be more applicable to patients who have late local relapses rather than early local progression, I believe.
We have a second question. If a patient has responded to a regimen containing vinorelbine cyclophosphamide, how many cycles will you continue it for? How long? What will be the duration of therapy for a relapsed patient?
Me to take this one?
Sure.
Yes, please, Dr. Mascarenhas.
Sure. So, on the data which we really have is on ARST 0921, where 12 cycles was prescribed. We have no way of verifying whether patients actually got 12 cycles or even got more than 12 cycles, but we presume most people followed the protocol. And I think that's what the data says. We don't have enough information to suggest that prolonging treatment really would prevent relapse or change the outcome. And again, this is something without data, but if there's no toxicity and everybody is in agreement, that's the patient, family, and the physician, it may be reasonable to continue therapy, but I would caution people to say that it's really without any data to support prolonged treatment.
Related question, would you ever consider maintenance therapy for a patient who has relapsed after the chemotherapy regimen you give?
Yes, I'll take that one. The discussion is, I think, much more vigorous now that we have had a presentation of the benefit of maintenance from a EPSSG prospective study, looking at the randomized addition of 6 months of maintenance with vinorelbine and oral cyclophosphamide, that improved overall survival in a population of patients who are initially non-metastatic, have achieved a complete response after initial frontline therapy, and have certain other clinical features. That's obviously very strong data since it was a randomized prospective study. But it's important to know that question, the benefit of maintenance, has not been asked in other clinical contexts, including at the time of recurrence. So it is possible that it would improve outcome, but not clear. And so I think one can consider that, particularly in those patients who have such a poor prognosis based on their initial relapse pattern. But I think we need to be very honest about the lack of strong evidence supporting that strategy.
I have another question, Doctor. This may be good for Dr. Mascarenhas. Say a patient has relapsed, but the duration of the relapse after many years, say 5 to 8 years after the initial treatment, does that period affect the way you think about the relapse treatment? If it is a late relapse, would you change your treatment for those patients?
I think when I was presenting the historical data, one of the factors which seemed to affect prognosis was the time to relapse. And so the earlier the relapse, the later, the earlier the relapse, the prognosis was slightly better, but not dramatically better. For reasons which I alluded to earlier, number one is, the baseline toxicity of the patient, the ability to tolerate toxicity may be a lot better if there's been a big break from someone who had got intensive therapy and relapsed right at the end of treatment versus someone who, relapses about 4 or 5 years later. The other comment I'd like to make is the possibility of reirradiation is that if a significant amount of time has elapsed, I think the opportunity, radiation oncologists may be more inclined to provide radiation therapy for local control. We do have a hint to suggest that patients who do achieve a second complete response or have adequate local treatment for the relapse have a better prognosis. So based on all that, I do think that affects your decision making when you select your regimen, and a patient who relapses really late, for example, who was not exposed to doxorubicin, cyclophosphamide, ifosfamide, and etoposide, who has a limited relapse, that may be a reasonable option. Again, we haven't studied late relapses separately to see what may be affected, but based on the data which is available, I think you can glean some of this information and make a good decision for your patient.
So this one is for Dr. Hawkins. Are there any current open phase 2 trials which you think have a strong data where you would favor this over the established ARST-0121 or ARST-0921 as first relapse in unfavorable patients?
I wish I could say that. The advantage that we had in the era of the ARST-0121 and 0921 was that we had a backbone chemotherapy for which we had a reasonably high confidence of response or disease control, to which we were layering biologic agents to ask a question and or different strategies. And we don't right now. The phase 2 studies we are investigating are single agent phase 2 studies, and without a known active, and by nature of being a phase 2, the question is there activity? And so I think that we a priori just don't have the same level of confidence of response or prolonged early disease control with these single agent phase 2s that we might have had with any of the combination therapies with a known effective backbone. So I think that may temper some people's enthusiasm about enrolling on a phase 1 or phase 2 at the time of first recurrence, and may, as Dr. Mascarenhas said, that may drive people to use that more for second recurrence or second or beyond recurrence.
A related question, are there any upcoming promising agents for relapsed rhabdomyosarcoma?
Well, I'm showing the slide. I went back to the slide of the drugs that are in development within the Children's Oncology Group, and there are a combination of different agents with different targets, including multi-targeted tyrosine kinase inhibitors, which I think have a rationale. I think there will be patients enrolled on the pediatric match who have rhabdomyosarcoma who happen to have a match recommended based on a patient-specific identification of a actionable alteration. Most of those alterations are not present at high frequency if you look at rhabdomyosarcoma in general. So I think the agents that might be exciting would be exciting on the patient level based on sequencing data obtained at the time of recurrence rather than at the whole level for all of rhabdomyosarcoma.
So I'm going fast because we have more questions.
Yeah.
Is there a role for radiation to the lungs? The patient has relapsed in the lung, but chemotherapy, they have remission of the tumor. Will you still radiate the lung?
Yeah, this is a good question that has not been adequately addressed at the time of recurrence, or for that matter, even at the time of initial presentation. We don't have strong data supporting the use of whole lung radiation in patients who present with initially pulmonary metastatic rhabdomyosarcoma. There's a retrospective analysis looking at patients who either did or didn't get radiation, suggesting an improved lung local control rate with whole lung radiation, but that's a non-randomized comparison. The EPSSG plans to ask that question as part of their frontline study to evaluate whether radiation to all metastatic sites versus only local control to the primary site improves outcome for metastatic rhabdomyosarcoma. And so perhaps we'll need to wait for that to answer the question. I think it's not an unreasonable strategy to provide whole lung radiation at the time of recurrence, but I think its true benefit is speculative.
So Dr. Mascarenhas, what would be your preferred therapy for a newly diagnosed stage 4 alveolar rhabdomyosarcoma patient, basically the highest risk patient? What would be your approach as the first line therapy?
So that's a loaded question. I think what is very clear is that, we tend to use the fusion status rather than whether it's alveolar or non-alveolar. So if you have alveolar histology without the FOXO1 fusion, those patients behave like embryonal rhabdomyosarcoma patients and seem to benefit where they have an intense alkylating therapy regimen. And so either treatment as per ARST 0431 or D9803 may be very reasonable for that group of patients. Based on the published literature, we really have treatment basically with VAC, or the European group had trial, on the Burney trial, and so an intense alkylator regimen, these patients still have a poor outcome. I think, and this has remained true across several decades. We really haven't made a dent in the fusion-positive, widely metastatic rhabdomyosarcoma patients. So philosophically, you could think a less intense regimen such as VAC-VI, would be reasonable for these patients. However, that's lacking data at this time. My personal practice, if there's no clinical trial available, is to offer patients based on what is published in the literature.
Thank you. So this will likely be the last question. This is for Dr. Hawkins. Role of PET scans in relapsed patients.
Yeah, I think it's probably an unstudied area. I think the potential benefit is in trying to sort through patients who have ambiguous imaging to confirm recurrence, or to try to identify a potentially more easily accessible site. There are some data at the initial presentation that suggests that we may identify more sites, particularly of osseous involvement or distant soft tissue involvement by PET scan compared to other anatomic imaging. And so I think there may be, if one is trying to get a complete metastatic evaluation, there may be some benefit of PET imaging compared to a combination of bone scan and MRI and CT scan. But I think it has been fairly understudied. I think for the patients who have fairly extensive metastases, it probably is of some benefit if we want to get a total picture of the sites of disease.
Thank you, Dr. Mascarenhas and Dr. Hawkins, for your excellent presentation and answering the questions. For the audience, thanks for joining us today. There is still time to register for the ASPHO conference. It's from May 1 to 4, and there is also a Rhabdomyosarcoma presentation by Dr. Hawkins on the Friday afternoon. So we all hope to see you there. Thank you very much for joining today.